So in the next 10 minutes, I'm going to take you through a couple cases and some pragmatic things that we did at University of Maryland when switching to biosimilars. So these are my relevant disclosures. So as I present these cases, I just want you to think about, is this an appropriate patient to switch? If you've already decided that no one's appropriate to switch, and you can turn your brain off for a couple slides. So this is a 21-year-old white man with strict-string ileocolonic Crohn's disease with upper GI tract and perianal involvement. He had an ileocolic resection in 2012, 3 years after diagnosis. He's currently on the innovator infliximab 5 mg per kg every 8 weeks, which was continued after surgery to prevent recurrence. He feels well. He's having 1 to 2 formed stools a day without rectal bleeding or urgency. He has no abdominal pain, fatigue, or extraintestinal manifestations. His inflammatory markers are normal, and his infliximab level is 3.8. Upper endoscopy and colonoscopy just 2 months ago showed no evidence of active disease in the upper GI tract, colon, ileocolonic anastomosis, or in the neoterminal ileum, including his upper GI tract and neoterminal ileo biopsies, which showed no active inflammation. So this is a patient in very deep remission. So is this patient appropriate to transition to a biosimilar infliximab? So the second case is a 31-year-old white female with left-sided ulcerative colitis diagnosed in 2015. She's on high-dose mesalamine, azathioprine, and infliximab, 7.5 mg per kg every 8 weeks. She feels well, having 1 to 2 formed non-bloody stools per day without urgency. She's having no pain or fatigue. Her inflammatory markers are normal, and she has both therapeutic infliximab and 6-thioguanine levels. Her colonoscopy a year ago demonstrated moderate endoscopic activity in the rectus sigmoid. We graded it as a Mayo endoscopic score of 2 with a normal proximal colon and TI. She's currently 22 weeks pregnant. So would you transition this patient to a biosimilar infliximab? So these are real, not contrived cases. So how do you transition a patient to biosimilar? So there are several keys, and these are things that we did from Maryland, which we learned from a very clumsy transition attempt at the VA. So one, education is important. So we developed a brochure explaining the concept of biosimilars with a nice, concise summary of efficacy and safety. This was in collaboration with our pharmacy. Initially, the educational materials from the company we thought were inadequate, so we developed our own educational materials. And secondly, the education extended to the nursing. So we have 2 excellent infusion nurses at Maryland. We made sure that they and the ancillary staff were educated about biosimilars because we allowed patients to have opportunities to talk to them about the switch to biosimilars. So this helped us to make sure that everyone at our center was on the same page and sending the same message about biosimilars. The transition, so once we came up with the educational materials and we trained the staff, we basically sent patients a letter informing them of our desire to switch, but we offered them an opportunity to meet with their provider before the switch. So we did not rush this process. This was a 6-month process at least. And during that visit, we again emphasized the efficacy and safety. We also it was important to discuss support programs for patients. So this really hasn't come up yet, but all of the biologic companies have excellent support programs with copay assistance and so forth, and we needed to make sure that we told the patients that those programs were going to be identical. There was going to be no additional out-of-pocket cost to them as a patient. And then I thought it was critical to have an open discussion with them about the benefits, how the switching was going to benefit them. Generally, it wasn't, although the savings that we estimated were being reinvested in our program, and it resulted in hiring a full-time social worker as well as a 0.5 FTE for a pharmacist. So we were very honest that those savings were being reinvested and were going to be coming right back directly to patient care. And then lastly, we allowed patients to have the final choice. So we did not force any patients to switch. If they, after all that education and discussion, if they still wanted to stay on the innovator product, we allowed them to stay on the product. And we decided not to make the switch at sensitive times. So case 2, 22 weeks pregnant, we did not switch that patient. We allowed her to get through her pregnancy without a problem, and then we actually switched her after pregnancy, after delivery. So sensitive times, right before travel, we didn't make a switch then. We also made sure that as much as possible, all patients were in a steroid-free remission. They were in biologic remission. They had therapeutic levels without anti-drug antibodies, and they had healed or minimally inflamed mucosa, which is what you should be doing in your practice anyway. That's no different than our current treat-to-target guidelines. But clearly before a biosimilar, particularly if you're thinking about worsening after the switch, you need to know that your patient is in a deep remission before you change. So what do you do if new symptoms develop after transition to biosimilar? So there's something called the Nocebo Effect. So nocebo is the evil cousin of placebo effect, and you have these patients in your practice that have multiple adverse drug reactions, and Dr. Moss is talking to them about going to new biologic, and they talk about their fear of side effect. They're already preconditioning themselves to have potential adverse effects of the drug. So if you don't frame this switch in a positive manner for patients, you're going to have what you call nocebo, which is estimated to occur in about 13% of patients to switch from an innovator to biosimilar. So if a patient develops symptoms, first you verify that they were in a deep remission before. You're still going to do an assessment for inflammation like you would do in any patient who's flaring. This will include serum biomarkers. I really like using calprotectin in these cases, so I'm just not automatically rescoping patients. If the calprotectin comes back as normal or low, this is very reassuring, and you can try to simply reassure the patient, and it's more cost effective than doing another colonoscopy. And certainly TDM can be appropriate. Marla mentioned that the assays measure the drug the same way. It is possible that you could have some dip in their drug level. So these are all things that should be done. And if there's any red flag present, calprotectin's elevated, CRP's elevated, certainly restaging them with an endoscopy or imaging would be appropriate. So if you suspect nocebo effect, so your workup is negative, there's no red flags, try to treat an alternate cause of symptoms. Reassurance can go a long way. Supportive care, and you can actually transition back to the innovator compound. This does reestablish response in a vast majority of people with nocebo effect. Marla also brought up that we don't have great evidence on multiple switches. We're actually going to see some of this data in the U.S. because in the VA they've already switched to one biosimilar and they now have a contract with another biosimilar, so we're going to get real world data on multiple switching, so stay tuned for that. But you can actually switch back if you have nocebo effect. So this was our experience at Maryland. So we estimated initially very substantial cost savings in switching. We identified 75 patients that were receiving infusions within our hospital infusion center that we felt would be eligible for the switch. However, in this process, which was somewhat drawn out, based on my recommendations, during that time, 39 patients were unable to switch due to third-party restrictions. So it wasn't quite the number of patients we thought. One patient was getting their product from an outside specialty pharmacy and wasn't eligible. And then during that time frame, as all of you are experiencing, 13 patients had to transition to an office space or home infusion. And 2 patients refused to switch. But we did have 20 patients who we switched, with a cost savings of about $8,000 per patient per year. And of those 20, 19 of 20 remain on therapy after 3 to 5 infusions. So stay tuned. I would say that's a very successful experience. So to summarize, nocebo effect is a development of symptoms after switching from an innovator to biosimilar product. It affects approximately 13% of patients. Nocebo can be minimized through education, emphasis on safety and efficacy of the switch, patience with the process, and shared decision making. We should also mention positive framing is incredibly important. Verify clinical, biologic, and endoscopic remission, or at least endoscopic improvement before the transition. And in any patient with worsening after the switch, evaluate new symptoms as you would loss of response for any treatment. All right, thank you very much.